Hello, welcome, and thank you for joining our webinar, Improved Accuracy and Patient Satisfaction Using Surface-Guided Radiotherapy to Avoid Marks and Tattoos in Radiotherapy. My name is Menna Creed and I'm the course director. If you're registered with CAMPEP or MDBC, please remember to take the quiz at the end. To receive your credits, you will need to achieve a mark of 8 out of 10. Credits are only awarded when the webinar is viewed as part of the live sessions. Throughout the webinar, there will be a live chat box. Please use the chat facility to ask questions to our presenters. This is live and interactive. We are lucky to have 3 clinical experts from around the globe presenting today. First, I would like to introduce Jackie Dorney, Specialist Service Lead, GenesisCare, UK. Jackie will present on marker-free radiotherapy and in particular present some of the audit results of markerless treatments in breast cancer.
Welcome to my presentation on surface-guided radiotherapy and marker-free treatments. My name is Jackie Dorney and I'm the Specialist Service Lead for the UK at GenesisCare. Vision RT have kindly invited me to talk about some of the work we've completed in the last year on surface-guided radiotherapy, and in particular the work completed by some of our teams in relation to treatments that require no skin markings of any kind. Most of this initial work has been completed with the help of some of our amazing staff in Nottingham in the UK, in particular Joanne Wrigley, whose research poster I will reference a little later in the talk. I hope you find my presentation useful, and I'll be here for questions should any of you want to discuss implementation of surface-guided radiotherapy or markerless radiotherapy into your departments. I thought I'd start with a brief introduction to GenesisCare, the company whom I've worked for the last 6 years. Internationally, GenesisCare is the largest private provider of radiotherapy in Australia, Spain and the UK. GenesisCare work and treat both private and public or NHS patients, with 27 sites across Australia and 28 across the UK and Spain, totalling 85 linear accelerators globally. In the UK, we have a mixed model of radiotherapy treatment centres and medical centres. Our 7 radiotherapy centres are built alongside a partner hospital for access to chemotherapy, diagnostics and specialised medical staff, and our 3 bespoke medical centres are standalone and offer radiotherapy, chemotherapy, diagnostics and outpatient clinics. We have a large portfolio of treatment techniques and pride ourselves on evaluating, assessing and implementing techniques into our centres globally in a streamlined and efficient way. Techniques such as VMAT, rapid access palliative pathways, SABRE, deep inspiration breath hold and IMRT can all be delivered as standard in a very short timescale, on the same day or within a few days of CT planning. I guess this gives you an idea of the progressiveness of GenesisCare and our will to continue to improve processes for our patients' benefit. So what is surface-guided radiotherapy or SGRT? Well, in the most simplest of explanations, it is a highly accurate camera-based system that monitors your patients in real time. It uses a series of camera pods, like those shown here, mounted into the ceiling in your treatment bunker. The camera pods consist of a projector and 2 image sensors, I like to think of them as eyes, that track the patient at all times. The way it does this is by using stereo vision techniques to create a 3D surface model of an object, similar to the way a human eye perceives depth in 3D. When the 2 separate viewpoints observe an object through the image sensors shown here on the device, the system uses the disparity between the images to create a 3D representation of what it's seeing. An algorithm works in the background once the positions, orientations and optical properties of the camera are known within the treatment room. Once the cameras are calibrated, a triangulation process creates the 3D coordinates of the patient through corresponding points, and a line RT finds these points by projecting a pseudo-speckle pattern onto the body of the patient. This generates around 20,000 points, or references if that's easier to understand, or around 20,000 virtual tattoos. You can see the pseudo-speckle pattern here on this slide projected onto the patient's skin surface, and also the camera's positions mounted into the ceiling of a bunker. 3 camera units, each with 2 sensors or eyes, are positioned into the ceiling of your treatment room and around your patient to create a complete model of the patient's surface, a 3D model of them. The system also allows for offline ROI definition, which is a crucial part of the process, as it's at this point you're focusing the camera system on the isocenter for treatment delivery. The whole surface is used for setup, but monitoring should always focus on the bit of the patient we are delivering treatment to. ROI definition needs to be considered carefully for size and position. As the system gives us picture quality images, we can really study the images for this definition process and exclude any areas that may be problematic. Stomas, catheters, open wounds, areas that are dressed on our patients. As the system is sub-millimetre accurate, small variances seen on the surface can cause issues if not thought about prior to monitoring. When thinking about surface-guided radiotherapy and markerless radiotherapy, I'm sure we've all seen patients marked in a way similar to the one shown here, either by a clinician or by their radiographers. Maybe it's CT, maybe every day for treatment, maybe a combination of both. Neither is ideal in any way. In one, the patient's skin surface is covered in pen marks, the other surface tattooed, leaving a permanent reminder, if not several reminders, of their radiotherapy. These are often visible when wearing swimwear or certain clothing items. Through patient forums and patient feedback, we've found this to be one of the main areas of concern for our breast and chest patients receiving radiotherapy. When asked, most said if they'd been given the option to not have any marks or tattoos, they would have chosen not to have any. Now, while this may seem trivial to some healthcare professionals, and some not seeing what the problem is with tattooing or marking patients, we must recognise that although we may have had to do this in the past, due to high fractionations, no alternatives to actually doing these tattoos, there are now solutions that enable us to stop doing this. We must remember that these are not our bodies to do with as we wish. We have to empower our patients to have as much control of their cancer journey as possible. Margarita Nibbs was one of our first Genesis Care patients to receive surface-guided radiotherapy treatment in Europe. She felt so empowered post-radiotherapy that she spoke to the UK press about tattooless radiotherapy and the fact that it made a huge difference to her physical and mental recovery. She spoke of permanent tattoo dots being a constant reminder of her cancer and one that she didn't want. We must encourage the individual needs and wants of our patients, and if tattoos and marks are a real cause of concern for them, we must try to facilitate a solution, in my opinion. We're very lucky at Genesis Care to have an SGRT systems that allow us to work markerless very easily, but there are many alternatives even if you do not. We progressed with SGRT not only because we wanted to move away from tattoos and marks, but also to improve our safety during beam delivery, being able to intrafraction motion monitor, and we wanted to develop an SRS service and also improve our deep inspiration breath hold technique. With the use of Align RT, the team in Nottingham have developed a technique that enables us to treat all of our breast patients without tattoos or marks, and the process and delivery has been mirrored at our Oxford Centre. Our results have shown that the Align RT software is as good as tattoo setups, and the patient feedback has been exceptional, with some of our consultants requesting their patients are treated with us due to this. So how does it actually work in practice? The DICOM data from the CT planning scan is pushed via the treatment planning system to the SGRT software. Here is an example of a visual representation of a patient shown from the DICOM data with a patient at isocenter. The table can be raised and free-floated into position using the visual display, simply by overlaying your patient on the couch to the visual display in Align RT. Delta values are shown here on the right-hand side of the screen to allow fine-tuning to ensure your patient is in exactly the correct position in all 6 degrees of freedom, without the need to make shifts to isocenter or mark your patient in any way. Should your patient move at all during beam delivery or image verification, the delta values shown here move in real time and will hold the beam, ensuring no dose can ever be delivered to the wrong area of the body. At Genesis, when we think to making changes to current practice, we always refer back to some of our key values, those of quality, access and efficiency. Some of these positive improvements relating to these values are seen here. So from a quality perspective, we've seen massive psychological improvement for many of our patients, especially those with tattoos that remain visible post radiotherapy treatment. From a quality perspective as well, we have seen a reduction in treatment errors from therapists aligning to incorrect tattoos or freckles. We've seen setup accuracy improve due to using 20,000 virtual points on the body rather than just 3 to 5 treatment tattoos. The SGRT system sees rotational issues prior to imaging, and we've also seen a reduction in the risk of our needle stick injuries with the elimination of tattoos. From an access perspective, patients are choosing to come to us so they don't have to have their permanent marks. And certainly we've seen efficiency gains, reduction in appointment times from 15 to 20 minutes to 10, and a greater throughput of patients per linac per day due to these decreased appointment times. Thinking about literature, there are many emerging papers being published around surface-guided radiotherapy solutions for markerless setups. There are some examples shown here on this slide. Papers are coming to the front around not only setups the markerless way for breast and chest patients, but also for head and neck, pelvis and complex high-dose treatments such as SABRE and SRS. All the papers shown here are supportive of positioning using the SGRT system to be the same as tattoos or better than tattoos and marks. None show an impaired setup. This makes perfect sense if you think about it as you're using the whole surface to align to, rather than just specific points that may be subjective for clinical reasons such as weight loss or weight gain. There has been a study completed by Landegg in 2016 that looked at fluorescent ink versus traditional tattoos and the correlation to patients' body image. You can see quite clearly here that they found a direct correlation between no permanent marks and increased body image both at 1 month post-treatment and 6 months post-treatment. When we implemented at Nottingham, the team led by one of our senior radiographers completed some in-house audit work that supports the literature seen to date. Elements of a recent paper Jo and her colleagues presented at the first European SGRT meeting are shown here. During radiotherapy, breast cancer patients are usually set up using dark ink permanent tattoos. This can have a big impact on body confidence and self-esteem due to the location of these tattoos. All patients receiving breast or chest wall radiotherapy between November 2016 and June 2017 at our Nottingham Centre were included in this evaluation. All were positioned on a breastboard with one arm above their head and immobilised with custom cradles. The first group received 2 standard dark ink tattoos and the second had none. As we know, Align RT assesses real-time patient positioning by comparison to the reference surface. As previously described, the delta values are created from the DICOM data disparity. The software registers the real-time surface to the reference and outputs the difference in position as a delta value in millimetres for 3 translations, vert, lat and long, and in degrees for rotations of yaw, pitch and roll. The delta values calculated are based on the region of interest defined on the surface by the radiographer. The study was supportive of the literature previously reviewed. Surface-guided radiotherapy setups are in all cases as accurate as tattoo and marker setups, and in some cases our more accurate alignment was possible using the Align RT software. This was especially prevalent for left breast cancer patients receiving deep inspiration breath hold. So in conclusion, we've found that SGRT is a win-win for Genesis Care. We must use the technologies available to us to help improve the lasting effects of permanent marks from radiotherapy treatments for our patients. We mustn't underestimate the psychological damage these marks can have on a patient and their body image during and post-radiotherapy treatments. Literature reviews have shown SGRT to be as accurate, if not more so, than setting up tattoos and marks across a range of body sites. And we've also seen improvements in safety, accuracy and speed of setups with less repeat imaging. I'd like to take this time to thank you for listening to this webinar, and I will be more than welcome to answer any questions any of you may have around this presentation. Thank you.
Secondly, I have the pleasure to introduce Sandra Paul, experienced radiation therapist and Head of Planning at the Alfred, Melbourne, Australia. Sandra will talk about digital positioning with SGRT and discuss the clinical advantages.
Hi, I'm Sandra Paul, Head of Planning at the Alfred Health Radiation Oncology Centre, Melbourne, Australia. My presentation today is a history of SGRT at the Alfred. I'm going to talk about the reduction of skin marks to no tattoos, how we use no skin marks on our breast patients, and future applications for SGRT at the Alfred. 2009 we installed Vision RT's Align RT system. We also got Gate CT and the Advantage workstation for 4D CTs. During initial testing of SGRT versus skin marks, we found that it was more accurate for breast, belly board and supine pelvises. So in 2010 we implemented it for these sites. Using SGRT, we import the CT dataset via DICOM. We use SGRT to position our patients. We also monitor throughout treatment. 6 degrees of freedom of information gives us real-time deltas, giving us the vertical, long, lat, yaw, roll and pitch. The RTs reduce the raw and roll and pitch deltas manually, either by moving the patient or asking the patients to move themselves. We then correct the vertical, long and lat by moving the couch. We find this helps to reduce pitch or rotation. This reduction of pitch and rotation also has meant we've had to do less imaging, thus reducing the radiation dose and time. SGRT for DRBH. Our patients are scanned in free breathing and in breath hold. Once it's deemed that DRBH is beneficial, we plan on this breath holds data set. Both contours are imported into Align RT. We position the patients on the free breathing data set. We have a 1.4mm setup tolerance. Once the patient is within tolerance, the breath hold surface has then selected. The patient takes a deep breath. When the Align RT deltas are within tolerance, then the patient has achieved the correct amount of breath hold. We have a 3mm tolerance for this. The gate beam function is enabled and treatment can commence. Advantages of using Align RT for DRBH. There's no external markers making it quick to set up. The actual area being treated is selected as a region of interest, and the 6 degrees of information helps eliminate back arching. The remainder of my talk is our never-ending journey on the process of reducing skin marks on our patients. So in the late 1990s we stopped tattooing our breast patients when it was noticed at follow-up that the tattoos were bleeding under the skin. Our then director, Professor Alan Roger, was quite adamant that we would stop this practice of tattooing on our breast patients. The Cancer Council of Victoria had also received feedback from patients that they didn't like these permanent reminders. So for the last 20 years our breast patients were treated using skin marks that we maintained. These skin marks represent rotation lines, midline, isocenter and the cut-offs where the fields enter the patient. During my time at the Alfred, I've been aware of patients removing their skin marks or asking if they could take them off because they were going on holiday between CT and treatment, going swimming, going to a function, or they didn't want their family or friends to see the marks, or even just going on a date. I'd also listened to the shock response from patients as they got off the CT couch at the drawings we had done. The patients felt it was really hard to maintain these lines. We also found that they were invasive. There was a risk to both patients and staff. They were unsightly, they were visible. These tattoos limited the clothing options for patients. So in 1998 we stopped tattooing all breast patients. There's an example of a normal tattoo at treatment, and the second one is at follow-up where you can see that the ink has bled under the skin. So as I said, for approximately 20 years our breast patients were treated using lines that were drawn on with non-toxic pens and maintained throughout treatment. We'd also record landmarks for all our patients so we were able to reproduce these marks if the patients lost them. Then with the implementation of SGRT in 2010 we became more confident that SGRT could deliver a more accurate setup than the skin marks on our patients, and it seemed superior to other sites that we were still tattooing. It took me a while, but in 2012 when I became head of planning I worked quickly to get rid of tattoos. This was because of my concerns mentioned before, and also we had 2 needle stick injuries within a month. This meant that all patients needed to be set up with SGRT. They needed to have temporary skin marks but no tattoos. So from 2012 we no longer tattooed any patients. There's a couple of slides of the marks that we put on our patient. When using SGRT, we'd always consider the skin marks on our patients to become less important. Over time, less and less skin marks were being maintained, and we're really only a starting point. But in 2015, we began implementing no skin marks on our breast patients. We'd started no longer maintaining cut-offs on the skin. We were not maintaining many marks at all. It was often only the rotation line, midlines, and a small isocenter mark. So the core group were confident that we could move to no skin marks on breast patients. We decided to start with breast patients because they were the ones that we felt impacted most by the marks. 2016 saw a big flood. It took out 3 of our 4 linacs, leaving us with only 1 linac. This very much slowed progress on getting rid of the marks on our patients. But in 2016, we trialled not using marks on a select group of breast patients. The patients loved it, staff were confident, and most importantly, the digital positioning showed the setup was accurate when we looked at the before imaging. And even during machine breakdowns or delays on the SGRT machines, the patients would prefer to wait and be treated with the light beam machine than to be treated with their marks. We did a retrospective study of 45 patients. There were 3 cohorts. Cohort 1 was treated without SGRT. Cohort 2 treated in conjunction with SGRT and skin marks, and Cohort 3 SGRT alone. There were 15 patients in each cohort. They had between 15 and 25 fractions. They were left or right-sided breast. There was no nodal irradiations, and they were not treated in breath hold. The graph shows the absolute displacement across the 3 cohorts. Cohort 1, this absolute displacement is 0.39. Cohort 2, it's 0.28, and Cohort 3, 0.27. The patients in Cohort 1 display a greater mean absolute displacement than compared to Cohort 2. There is no statistical significant difference in measurements between Cohort 2 and 3, indicating that the removal of the skin marks had not led to any reduction in setup accuracy. Many studies have previously reported that patient setup with SGRT systems is more accurate than skin marks alone, and the results from these investigations also suggest this. We think the slight reduced absolute displacement between Cohort 2 and 3 might relate to the fact that the RTs are not distracted by the lines. We would plan to review more patients. There was one patient in Cohort 3, represented by the dot. She was a real regular, and we noticed via SGRT that she relaxed, moved every time we left the room. In hindsight, we probably should have done a line RT ISO move on this patient. Moving to a clean skin. In summary, next challenge, no mark on anyone's skin. SGRT was currently only being used on patients that were 5 fractions or more, and it was thought that this palliative cohort really could benefit from being treated with SGRT, would help us to address their pitch, roll and rotation, and also help us to monitor them as we left the room. This was also an important step in the quest to go markless, because all patients needed to be treated with SGRT. So June 2017, we began treating all patients, including single fractions, with SGRT. I feel we're getting closer to no marks on anyone's skin. Our next step is to trial no marks for various sites. This is on track for early next year, as we are currently submitting to the Alfred Health Innovations Committee for permission to trial this on patients. We've also just put SGRT at one of our regional centres at the Latrobe Regional Hospital. They've started treating DRBH, which means patients no longer have to travel the 2 hours each way to Melbourne for treatment. I would like to thank the staff at Radiation Health Oncology, and also special thanks to the following staff. Thank you for your time.
And finally, I would like to welcome Ellen Herron, Senior Radiation Therapist, Northside Hospital Cancer Institute, Atlanta, USA. Ellen will present on the practicalities of transitioning to a markerless setup, a guide for a seamless transition.
Hi, my name is Ellen Herron, and I'm a senior therapist at Northside Hospital Cancer Institute out of Atlanta, Georgia. Today I'm going to be presenting on transitioning to a markerless setup, and it's a guide for a seamless transition. Like I said, my name's Ellen Heron. I've been a therapist for over 10 years, and we've been using Align RT at our center for about 3.5 years now. We've actually, we love the system, and it's been so successful. We've just recently transitioned all of our patients to a markless setup. So today I'll kind of be going over some of the things that helped get us there. And just a quick disclosure, we are a reference site for Vision RT, so they do pay us for Center of Excellence. Just some of the objectives I'm going to be going over today. I'll be discussing the benefits of a markless setup compared to the traditional setup with marks. It increased our efficiency, it increases our accuracy, and the best part of all, it increases patient satisfaction. Another thing I'll go over is some of the management and troubleshooting and some of the obstacles we faced before the transition, and just some things we looked at before we made that transition. And then I'll go over some tips and examples of ROIs, so you can get the perfect ROI. And then I will walk through an example of a patient who has a markless setup, just to show you how simple and easy the setup actually is. So first of all, before starting the transition, there's some essentials. And obviously the first one is having the Align RT system and software. I left that off the list, but that's an obvious. Next is fully trained therapists, dosimetrists, and physicists that have preferably been to training that Vision RT offers. And then willingness to learn a new technology and an open mind. I'm lucky within our department we have a doctor who supports that, and also therapists, and the whole team is excited about new technology and using it. So, and then lastly, to use backup marks until you are completely confident in the system before that transition. And we made a pact when we got Align RT to use it on every patient, so we did get comfortable. And over time, we were so comfortable with the system, we decided we could get rid of the marks. So the major benefit is patient satisfaction. And this, we found out, it lowers patient anxiety for patients not to have marks. So then they can focus on their healing and rest instead of worrying about if their marks come off or not. Another benefit is there's no visible marks for others to inquire about. So some patients keep their treatment a secret, so their work won't know, or no nosy family members. So no marks. Sometimes if patients wear a lower shirt or certain clothing, marks can stick out in this way. There's nothing for others to inquire about. Also, there's no constant reminder of the hardship they're facing. Whether it be tattoos, permanent or semi-permanent marks, this eliminates that reminder altogether. The next one is it offers a worry-free treatment as far as patients can continue their activities such as swimming or exercising, and then obviously they're able to do baths that they might not normally be able to do with stickers or marks. And then it's also, we found out, a great option for patients that are allergic or sensitive to adhesive. And then one of the best things that our doctor loves is that it eliminates the need for rescans for patients that lose their marks. And recently we found out you can actually use the Align RT system in the room to recreate setups where immobilization devices have been thrown out or have malfunctioned. So that actually saves the patient from being rescanned, the doctor from replanning it, and the whole planning team from replanning it and QAing it. So it's kind of a benefit for everybody and therapists. So the next benefit is efficiency. It reduces our repeat imaging. Align RT can detect the roll and rotation better than any mark ever could. So that's a huge plus for the therapist and the patient. Another thing it does is allows all therapists in the room to see the shifts needed to get that patient in the correct position. So normally with a traditional setup, you have a therapist on each side of the table, and you set to your mark, and the other therapist confirms that they're on their mark, and you just kind of take their word for it. This way, every therapist in the room can confirm that patient's in the correct position before stepping out of the room. It also reduces excess maneuvering and skin manipulation. A lot of times as therapists, we over-move patients, and if you need a roll, one therapist can say a half cm, which it might not be equal to the other therapist's half cm. So we've learned that we're over-rolling and rolling back. And this way, with Align RT, you can see the exact movement you need to go, so it cuts down on the over maneuvering patients. It also eliminates the bad habit of manipulating the skin to your mark, which in reality, usually it's the body that needs to be moved and not the skin. It's also simplified all of our setup procedures. As a senior therapist, I like to keep setup procedures consistent throughout the department, and there's one way to set these patients up, and they're all used by setting up to Align RT, and that just cuts down on errors and confusion between the therapists. It also eliminates the manual shift on verification day, which is a huge bonus. So don't pulling out your calculator and calculating a shift, or trying to do it in your head, which also eliminates human error as far as that goes. All right, another benefit is accuracy, and I can't go into much detail about this. We're currently collecting data that I believe will prove that Align RT is more accurate than the traditional setup with marks. And we're also collecting that data for efficiency, so it'll be exciting to see the results when we get that back and compile it and analyze it, and hopefully one day we'll publish it. Cost. As far as cost, this eliminates the need for stickers or paint pens, which may not sound like much to some people. So I looked at the purchase orders for a year when we were using marks and paint pens, and calculated up about how much you would save going to a markless setup. And it averaged about $6,000 per year per machine. So if you were to have multiple machines, it could add up. Another thing it eliminates is the infection control element. There's no shared paint pens. And then it completely eliminates the needles and the ink. And then also it eliminates the need to pull people's stickers off, which sometimes can create skin trauma or peel the skin back. The next benefit is a marketing benefit. I personally believe that SGRT, and along with imaging in some cases, is going to be the way of the future. Marks are going to be a thing of the past. So it's a fairly new concept. It gives you the opportunity to be a leader in this movement. So next we'll go over some management and troubleshooting, and these are just some of the things we looked at before making that transition. The first one is indexing. This was a huge tool for us in confirming that the patient is in the correct position along with the SGRT. So we currently index every single patient that we have. Before we went markless, there were some patients we did not index. So we've kind of got creative with some of our setups to figure out a way to index every patient. And then the table parameters are acquired on the first verification day and every film day. And we use those parameters along with the SGRT to set the patients up daily. And then as far as planning goes, they use tighter tolerance tables. So if a patient were too far off, we would be alerted in the treatment room. Another thing we looked into were transfers. We are one center of 6 in our system. So this was a big one for us, but it's kind of important to have your protocols in place before you make that transition. For our center, if we know in advance a patient is going to another center, we automatically give them marks in CT for their CT0 marks. If for some reason they were transferred during treatment, our first choice would be send to a machine that has Align RT. And then if that machine was too busy, the second choice would be you could set them up, mark them with that Align RT machine, and send them to another machine for treatment. And then the last resort, if it needs to go to a machine that doesn't have Align RT, to use your imaging capabilities and SSD checks before treatment. Another thing we encountered were software issues. At our center, we've been lucky. We've never really had a time where the software was down for an extended period of time. Most little glitches we can fix by restarting the computers and the cameras. So we haven't really encountered an issue with that. If there ever was a time where a line RT was down for days or hours, then obviously DIBH patients would be sent to a center that had a line RT and could be treated. And then the rest of our patients, we would use their required table parameters and imaging and SSD checks before we began treatment. And then obstacles, all these obstacles I came up with and sat down with the clinical team, a director, a chief physicist, a chief dosimetrist, and a coordinator to make sure we were covering all our bases. And then, like I said, one of those big tools that we realized was our indexing. And then I tell my therapists to have common sense, and if you're ever questioning a setup or a setup is questionable, then by all means place marks if it will reassure you. And then obviously don't make this transition until everyone is completely confident in the system. And the next section is ROI Selection, and first I'll just give some tips on selecting your ROI. This is the start of the setup process in our department, and in our department the therapists select the ROI. You want to encompass the body part that is being treated and then the stable tissue around it. And one of the benefits of a line RT is that you can focus on that entire body part instead of a small area where marks were to be placed. Another tip is to extend the ROI so it's visible by all the cameras, and this will allow a line RT to still monitor when your imaging blocks a camera or the gantry blocks a camera. And then if possible, you want to leave out any creases or folds and any movable body parts. So for our head and neck patients, we cut out the eyes and the mouth, anything that can move or skew a line RT. And then exclude anything not present in CT that was on the skin surface. So for an example, if the patient has a Band-Aid or if they got a part, we would eliminate that from our ROI. And so here are just some examples of how we select our ROIs. This first patient is just a regular breast patient. She's having tangent breast treatment, and you see we encompassed her breast and then some stable tissue around it. And then the next one beside it is a breast patient with the superclad field, and we just went a little more superior with her ROI to encompass that superclad. For our head and neck patients, we use a clear vision mask and it's open face. So for these ROIs, we select where the mask is open, and then we cut out the eyes and the mouth. And then for this last example, it's an extremity patient, which a line RT does wonders for extremity patients, like I said, because it can detect the roll and rotation better than any mark. So we know that before we even leave the room. And so it definitely reduces repeat imaging procedures for extremity patients. So you see here we highlighted the shoulder that's being treated and then a stable part of the body, and then eliminated the armpit where that big crease and fold is. So I just wanted to run through an example patient just to show you how easy and simple this whole setup is. This is just a breast patient, and we'll start with verification day. The patient's imported and the ROI is drawn, and like I said, that's done by our therapists here in the department, and that's usually done on the pre-treatment check, which is done the day before or the morning of. And then when the patient comes in the room, the shifts are made using the line RT. Images and SSDs are taken, and when those are all correct, we capture a new reference image. And then the table parameters are also acquired. That new reference image and the acquired table parameters are the tools we use to set that patient up the next day. And then lastly, a picture is taken of the lasers on the patient and the field light for chart documentation. So for treatment the next day, the table is raised to the acquired table parameters, and then the patient's set up using a line RT. We check the medial light field, and we verify the SSDs, and when all these are in tolerance, we begin treatment. If for some reason the patient were to move or sink down out of tolerance during treatment, we simply go into the room and adjust according to the system and then continue treatment. So I just added a couple quotes from, this is our doctor and one of our therapists in our department. And the doctor says, "I love the fact that if an immobilization device malfunctions, then the therapist can use the information stored in the system to create one rather than have the patient rescan and replan." And then the therapist's comment was, "Besides the fact that a markless setup is quicker and more accurate, I also love the fact that all therapists in the treatment room can see movements needed. This eliminates the need to talk over patients during our setup procedure." And that just shows you an example of how it's actually simplified our setup.
Thank you for taking the time to be part of our webinar, and don't forget to take the quiz to obtain your credits. This webinar will be available for future viewings at www.sgrt.org, along with other useful information. Again, thanks for joining and have a great day.